I am going to give a talk that is meant to follow my prior talk on myocardial infarction updates and is organized in multiple board-style questions. All the questions and explanations are obtained from the second edition of my book, Practical Cardiovascular Medicine. This is the first question. A 71-year-old man presents with inferior STEMI and hypotension. He receives primary PCI, but he remains hypotensive with systolic pressure of 75 millimeter of mercury despite 2 liters of normal saline. Right heart catheterization shows RA pressure of 25 millimeter of mercury, wedge pressure of 22, PA pressure of 45 over 22, and cardiac index of 1.5 liter per minute per meter square. What is the next step? Additional saline boluses, B, dobutamine, C, balloon pump, D, right-sided impella, and E, ECMO. The answer is B, inotrope. This patient has the hemodynamic profile of RV shock. In RV shock, PC wedge pressure may increase because of ventricular interdependence, meaning the RV pushing against the LV and forcing equalization of diastolic pressure. Subsequently, the PA pressure may rise because of the rise of PC wedge pressure. It's a passive post-capillary increase in PA pressure from that rise in wedge pressure from ventricular interdependence. In fact, in shock trial, wedge pressure was equally elevated in LV shock as in RV shock. The first treatment of RV shock is fluid administration up until RA pressure of 10 to 14 millimeter of mercury. Once the RV dilates, further fluid administration will worsen ventricular interdependence, further reduce LV output, and increase backward tricuspid regurgitation. Thus, 500 milliliter of fluid boluses are provided while carefully assessing JVP and the hemodynamic response to each bolus. Boluses are stopped if JVP reaches around this number or if no improvement in systolic and pulse pressure is noted. The number of 10 to 14 millimeter of mercury has been provided by this landmark analysis in 1990, which showed that the best stroke volume in acute RV infarct is seen when RA pressure is 10 to 14 millimeter of mercury. Beyond this RA pressure, the stroke volume actually declines because of what I explained: ventricular interdependence, a decline in LV outflow, and an increase in RV afterload and tricuspid regurgitation. Now, the second line of therapy, if the patient does not respond to fluid boluses or after he reaches that 10 to 14 millimeter of mercury of RA pressure, is inotropic therapy. The third line of treatment is balloon pump. Now, how does balloon pump help RV shock? This is how it helps RV shock. It's really a direct effect on RCA flow and RV perfusion. Balloon pump increases diastolic RCA flow and therefore increases RV perfusion directly. This is aside from whatever effect it has on the left ventricle. This helps as well. Balloon pump will improve any component of LV failure contributing to shock, and that helps. But the primary effect in RV shock is the increase of RV perfusion. That said, balloon pump is the third line of therapy and is reserved for RV shock refractory to inotropes or RV shock with a clinical left heart failure. The fourth line of treatment after exhausting the first three is right-sided impella and ECMO. Therefore, in this patient, the answer is B, inotropic therapy. Which inotrope to use in RV failure? Since at least half of the RV coronary flow occurs in systole, RV coronary flow depends on the driving gradient between systolic blood pressure and RV systolic pressure, at least as much as the gradient between diastolic blood pressure and RV EDP, the latter gradient being improved with balloon pump if used. But this dependence of the RV myocardial flow on systolic blood pressure explains why RV is very sensitive to decreased systolic blood pressure, more so than the left ventricle, which may actually thrive with a slightly reduced systolic blood pressure that reduces LV afterload. In fact, the LV coronary flow is mostly diastolic, 80 to 85% diastolic, which explains that this LV flow is not dependent as much on systolic blood pressure, and that explains why the left ventricle may actually thrive with a slightly reduced systolic blood pressure that improves the LV afterload. But to go back to the right ventricle, this explains why inotropes used in RV MI should be able to increase systolic blood pressure, and therefore norepinephrine is often the agent of choice. Next question. A 62-year-old man with a history of CABG presents with persistent chest pain for the last 2 hours. ECG shows diffuse ST depression, most pronounced in leads V1 through V4, and approximately 3 to 4 millimeters in lead V3. High sensitivity troponin is detectable, but below MI cutoff. What is the next step? A, aspirin and heparin, B, serial troponin measurement, or C, aspirin and fibrinolytics? The answer is C, fibrinolytics. In fact, persistent chest pain with ST depression that is isolated or predominant in V1 through V4 indicates a posterior STEMI, particularly when associated with a large R wave. Performing posterior leads EKG increases the diagnostic yield, but regardless, this patient is managed as posterior STEMI with fibrinolytic or preferably with a primary PCI, even if the posterior leads do not show ST elevation. And keep in mind that when you do posterior lead EKG, only 0.5 millimeter of ST elevation is significant in the posterior leads. As the posterior leads are far away from the heart, so ST changes are attenuated and less ST elevation is more significant. On occasion, the posterior leads may not show ST elevation in a patient with posterior infarct. Hence, we take into account that anterior ST depression we take it into account and we treat accordingly. This is the third question. A 68-year-old man presents with anterior STEMI and receives a primary PCI of the LAD. EF is 40%. On day 3, he collapses while walking in the hospital hall and is found to have a monomorphic wide complex tachycardia, which is successfully DC cardioverted. Post-cardioversion EKG is unchanged. Anterior Q waves, no ST abnormality. How should this patient be managed? A, repeat coronary angiography. B, amiodarone. C, ICD placement. D, EP study. And E, live vest. The answer is C, ICD placement. For the following 2 reasons. Monomorphic VT occurring anytime after MI is a marker of a permanent substrate from a prior scar rather than acute ischemia. Acute ischemia leads to polymorphic VT or VFib, not monomorphic VT. The second idea is the fact that this VT is occurring more than 48 hours after MI also suggests a permanent substrate and implies the need for ICD. Acute ischemia may facilitate the induction of monomorphic VT, but is not usually the cause of it. Since EKG is unchanged in this patient, coronary angiography is not needed. This is another question. A patient with inferior STEMI just underwent primary PCI of the proximal RCA. In the cardiac care unit, his monitor shows complete AV block with a junctional escape rhythm of 40 beats per minute for 5 minutes, which subsequently resolved. He felt dizzy but did not experience chest pain recurrence. What is the next step? Continue to monitor, place a transvenous pacemaker, administer atropine. The answer is A, continue to observe. Complete AV block in the setting of inferior STEMI is usually well tolerated and does not require pacing unless persistent and associated with severe symptoms or hemodynamic compromise, more so in the case of RV shock. Complete AV block in the setting of inferior STEMI is a nodal AV block and is associated with a larger MI, more RV MI, and a twofold higher in-hospital mortality. However, in patients who survive to hospital discharge, the long-term mortality is generally not affected. Next question, a patient with anterior STEMI just underwent primary PCI of the proximal LAD. In the cardiac care unit, his monitor shows complete AV block with a slow escape for 15 seconds, which subsequently resolved. He feels well now. His EKG shows right bundle branch block and the residual anterior ST elevation with Q waves. What is the next step? A, continue to monitor. B, place a transvenous pacemaker. C, administer atropine. The answer here is B, place a transvenous pacemaker. In fact, complete AV block in the setting of anterior STEMI requires transvenous pacemaker placement even if transient, as it is more hemodynamically compromising with slower and less consistent infranodal escape. It is a high-risk rhythm and is associated with a fourfold increased mortality, mainly related to the large size of the infarct and pump failure rather than AV block. Next question, a 79-year-old man presents to a rural hospital with inferior STEMI. He receives tenecteplase and is transferred to your facility. On arrival, ST elevation has resolved, but the patient is dyspneic and distressed. BP is 90/70, JVD is present, lungs are clear, and heart sounds are distant. Which hemodynamics are consistent with this clinical picture? A, RA pressure 18, PA pressure 30/18, and wedge pressure 17. B, RA pressure 18, PA 28/13, and wedge pressure 13. C, RA pressure 8, PA 50/23, and wedge pressure 23. And D, RA pressure 18, PA 50/23, and wedge pressure 23. The answer here is A. In order to reach this answer, we have to make a diagnosis. The diagnosis is most likely tamponade from LV free wall rupture precipitated in an elderly patient over the age of 75 by thrombolysis. It's a known complication of thrombolysis in elderly patient, as well as thrombolysis in late presenter over 12 hours. Since we know that's the most likely diagnosis, then we can pick answer A, because in tamponade, our A pressure is approximately equal to wedge pressure and is equal to PA diastolic pressure. This is what we call equalization of diastolic pressure. This patient may also have RV infarct in the setting of inferior infarct. But even if your answer is RV infarct, the hemodynamics will most likely be the same, also answer A. As I explained in a prior question, RV infarct frequently leads to equalization of diastolic pressures as well because of the ventricular interdependence, and therefore frequently RA pressure and wedge pressure are approximately equal in RV infarct. Also in RV infarct, wedge pressure is expected to increase in an elderly patient with a concomitant LV infarct. So answer A is the correct answer both ways, although I think in this patient, tamponade is the most likely diagnosis considering the age and the use of thrombolysis. Next question, a 62-year-old man with a history of single vessel CAD, a known occlusion of the left circumflex artery several years ago, presents with episodes of severe dizziness and palpitations over the last 24 hours, followed by a fall and near syncope. Emergency medical personnel successfully cardioverted him, as you can see in the figure. Subsequent ECG shows anterolateral ST depression, which resolves 5 minutes later. He denies any chest pain. Troponin level is 7 nanogram per milliliters, and creatinine and liver tests are acutely elevated. Emergent coronary angiography shows no left main or LAD disease. 100% proximal left circumflex occlusion involving a high and large OM branch, and 80% mid-RCA smooth stenosis. What is the next step? PCI of RCA, no need for ICD placement. B, PCI of RCA followed by ICD placement. C, ICD placement, no need for RCA PCI. D, FFR of RCA. E, PCI of left circumflex occlusion. Again, this is the EKG. Look at it carefully. The answer is C, ICD, no PCI. This EKG shows a monomorphic VT secondary to a scar from a prior left circumflex, high OM or ramus anterolateral infarct rather than acute RCA ischemia. Monomorphic VT is secondary to scar rather than acute ischemia, as we discussed on a prior question, and the known history of occluded left circumflex is further suggestive of that. The patient's echo confirmed the presence of a thin and akinetic high lateral wall. PCI of RCA is only helpful in the setting of polymorphic VT with ongoing signs of ischemia, such as persistent chest pain or persistent ST anomaly. Not the case here. Troponin rise and ST depression are rather secondary to VT and prolonged hemodynamic compromise, not the other way around. In fact, that same hemodynamic compromise explains the acute renal injury and the shocked liver in this patient. The only specific VT treatment here is ICD. RCA stenting is unhelpful and may hinder ICD placement, as insurance payers may not cover ICD costs in the 90 days following PCI. Therefore, beware of coronary angiographic findings in the setting of monomorphic VT. A coronary stenosis in a patient with monomorphic VT is frequently and overwhelmingly an incidental stenosis, the treatment of which does not affect VT recurrence. And this is a statement from the ACC/AHA guidelines in 2018. In patients with ischemic heart disease and sustained monomorphic VT, coronary revascularization alone is an ineffective therapy to prevent recurrent VT. Next question. An 80-year-old man presents to a rural hospital with STEMI. He receives tenecteplase and is getting transferred to a PCI facility. What drug should he receive before transfer? A, clopidogrel 75 mg, B, clopidogrel 300 mg, C, clopidogrel 600 mg, or D, prasugrel 10 mg. The answer is A, clopidogrel 75 mg. A patient older than 75 treated with fibrinolytic therapy should only receive 75 mg of adjunctive clopidogrel. Should he eventually undergo PCI in the first 24 hours, 300 mg of clopidogrel may be loaded. 300 mg of clopidogrel is the only ADP antagonist used in pharmacoinvasive trial wherein PCI is performed within 24 hours of thrombolysis. Prasugrel and ticagrelor are contraindicated in the first 24 hours after fibrinolytic, and prasugrel is relatively contraindicated at age over 75 anyway. Next question. A 62-year-old hypertensive man presents in the late evening with a prolonged episode of chest pain that occurred at rest and lasted 1 hour. Chest pain resolved in the emergency department after initiating heparin, metoprolol, and nitroglycerin drip. ECG shows mild lateral SC depression and initial troponin is 0.08. The nurse notes a 30-second run of VT on telemetry that resolved spontaneously. He is comfortable, chest pain free, with a blood pressure of 132/82 and a heart rate of 75. What is the timing of cardiac catheterization? A, within 2 hours, B, within 24 hours, such as next morning, or C, within 72 hours? The answer is A, within 2 hours. This patient with non-STEMI has developed sustained VT, defined as VT lasting 30 seconds, which is a sign of electrical instability, even if it has spontaneously resolved and has not recurred yet. In non-STEMI, the indications for catheterization within 2 hours are the following 3. 1. Persistent or recurrent chest pain or deep ischemic ST depression that is persistent or recurrent. Number 2, hemodynamic instability. Number 3, electrical instability, which is sustained VT. Next question, a 55-year-old man has a history of untreated hypertension. He presents with chest pain and dyspnea. He has severe hypertension upon presentation, 190/110 millimeter of mercury. After the administration of 2 nitroglycerin sublingual tablets, chest pain resolves and BP declines to 145/85. Troponin I is 0.04 and peaks at 0.15 nanogram per milliliter. What is the diagnosis and what is the next step? A, this is type 1 MI from plaque rupture, must perform early invasive strategy. B, this is type 2 MI from severe hypertension. Hypertension control is the initial measure. The answer is A, type 1 MI. In fact, patients with true ACS type 1 MI may have hypertension that is secondary to the distress of angina. The quick resolution of hypertension with nitroglycerin implies that hypertension was secondary to myocardial ischemia and catecholamine surge rather than a cause of ischemia. Even the mild troponin rise in context is worrisome for true ACS and plaque rupture. Next question, which builds on the prior question of ACS and hypertension. A 55-year-old man has a history of untreated hypertension. He presents with chest pain and dyspnea. He has severe hypertension upon presentation, 220/120. His pain and hypertension do not improve with nitroglycerin and require a 24-hour intravenous drip of nicardipine and multiple agents to control hypertension. ECG shows LVH with a strain pattern. Initial troponin is 0.08 and peaks at 0.6, more than the prior case I showed. Creatinine is 1.5. Echo shows LVH with mild LV systolic dysfunction and elevated LA pressure. What is the diagnosis and the next step? A, type 1 MI must perform early invasive strategy. B, type 2 MI from severe hypertension, just control the blood pressure and eventually perform stress testing once hypertension is controlled. The answer here is B. Unlike the prior case, this is the case of a patient with persistent severe hypertension requiring multiple agents. Persistent hypertension and its requirement for multiple agents implies that malignant hypertension is the primary process responsible for the patient's pain and troponin rise. Troponin is usually less than 1 nanogram per milliliter in these cases, as in most cases of ischemic imbalance. Ischemic workup, possibly stress testing, may be performed once hypertension is controlled and chest pain resolves.